Margaret and I are pleased to talk to you today about some of the collaborative work that we've done from 2 different health plans in Minnesota to increase the rates of chlamydia screening. The health plan that I work for, Medica, is a 1.5 million member health plan based in Minneapolis and serving the states of Minnesota, North and South Dakota, and western Wisconsin. And we include all lines of business, including commercial or employer-sponsored healthcare, individual, Medicare, and Medicaid plans. So before we talk about some of the collaborative work that we've done, it's important to set the stage and describe a little bit about what the healthcare landscape is like in Minnesota. And so on this slide, we're showing some of the major hospitals and health systems and all of the licensed health plans or HMOs in the state. It's important to note that by law, all health plans are nonprofit. And I think that that really does make a difference and influence the work that we can do collaboratively together. And you'll notice that on the health plan side of this slide, United Health Group, the largest health insurer in the country, who is based in Minnesota, is not shown here because they are not licensed in Minnesota because they are a for-profit organization. And to point out how this slide is laid out, it kind of is a map of how we are organized as different companies and organizations. So on the left-hand side, you see hospitals and health systems, which are the major players in the state. Of course, there are a lot more hospitals and clinics than are shown here, but these are the bigger players, most of which are based in the Twin Cities metropolitan area, with the exceptions being Essentia Health, based in Duluth, Sanford Health, based in Sioux Falls, South Dakota, and a little clinic system in the south of Minnesota called Mayo. And then you see that Health Partners and Sanford are both straddling the center line because they both include provider sides of the organizations and payer sides of their organizations. You'll notice that Medica and Alina are side by side. We used to be a single organization which included both providers and payers. We are now independent organizations. You'll see Part Nicollet being run under Health Partners. They merged at the beginning of this year into one organization, although they have kept both names. And it's also important to note that all of the health plans that are licensed in Minnesota must serve public programs or the Medicaid program. Minnesota is a Medicaid managed care state, which means that most of the enrollees in the Medicaid program get their coverage through one of the HMOs or managed care organizations. And this slide points out some of the different programs that Minnesota has to serve our Medicaid and other populations. And I want to point out the Minnesota Care program, which has been in place for 20 years, is kind of made up for some of the people that Medicaid doesn't cover because they are employed and are earning too much money to qualify for Medicaid, but they don't have access to or can't afford their own insurance. And so it's a state-sponsored, subsidized, sliding fee scale insurance program, which is one of the reasons that Minnesota has traditionally had one of the lowest rates of uninsurance in the nation. And then at the very bottom of the slide are some of the newer programs coming into play, largely because of the Affordable Care Act, that will bring more people into coverage. We do a lot of collaboration in Minnesota, and part of the reason because it's very systemic. It's part of the system we have in Minnesota. And this slide outlines 3 of the sectors, local public health, health plans, and hospitals and health systems, that at different points in time and through different vehicles have been brought into community health and collaboration. And so a lot of the reason that we do so much collaborating in Minnesota is because at some level we have to, but of course we also find that it's much more effective to do community health improvement in a collaborative fashion and to involve as many of these sectors as possible. The hospitals and health systems through the Affordable Care Act are just now getting into having to do their community needs assessments and community benefit plans. So this is new territory for them. And here in Minnesota, we have had some meetings getting the 3 sectors together to align all of our efforts so that we're not duplicating and creating additional work. Margaret.
Thank you, Ken. Hello, everyone. As mentioned, I'm Margaret Crawford. I work here at Blue Cross Blue Shield of Minnesota, and I'll be speaking and sharing with you on how our health plan collaborative works here in Minnesota. First of all, how do we work as a collaborative? Well, some of the health plans have been doing collaborative PIPs since 2007. And as Ken mentioned, we have a unique perspective here in Minnesota, and I wanted to go over what we've learned along the way. It's very important to have positive team structure and team dynamics. It's great when you have diverse backgrounds and skill sets of our team members on the collaborative. When you pool talent from different organizations, it really increases the project's knowledge base. When you share vision, and share vision also allows for consistent messages to our providers, they see us as more of a united front. And there's always efficiency in teamwork. It's more effective and it's just more fun to work with a team. Some things that one may have to look out for is that plans may have different levels of interest in some topics sometimes and resources available, such as budgeting and staff. And then with any team, you want to watch out for the extroverts and the introverts and hearing the little voices. Also, working with an independent third-party QIO or quality improvement organization is essential for data pooling and for aggregating our data. When we work with other plans, we really spread out the workload. It makes the project more manageable, costs are shared, and again, we have the team approach. Some concerns may be when PIP selection and development of the collaborative can be time-consuming, especially at the beginning of a project. You have a lot of meetings. You might meet 2 to 3 times a month to pick the topic selection. You have to do research. You may do some surveys. You also want to include your data and analytical staff back at your organization. And you also want to partner with your internal contacts, your medical directors, your leadership, your legal department when the project starts and throughout the project. Now I'd like to specifically talk about a collaborative project we've just started here in Minnesota. We have just begun the Chlamydia PIP project. This started in 2013. It's a collaborative effort among 4 Minnesota health plans. We have project support from our QIO collaborative consultant, Stratus Health, and this really makes our PIP process go smoothly. We appreciate their guidance and their insights, and we have a wonderful group of people that we work with at Stratus. We've also partnered with the Minnesota Chlamydia Partnership Group, organized by the Minnesota Department of Health, an external partner. And this in and of itself is another unique collaborative, health plans working with a little section of the Minnesota Department of Health. Please check out their website if you get a chance. We're so very happy we've teamed up with them. Our Chlamydia PIP project is to increase chlamydia screening rates for women ages 16 to 24 among our medical assistance population. How will we do this and what will we do? Our project goals and interventions are to work on provider trainings, produce a provider toolkit. We also want to perform targeted outreach to some of our low-performing clinics. We want to support the implementation of the Minnesota Chlamydia Partnership Strategy. Again, another unique collaborative. We feel that we've connected well and are so happy to be moving forward with that. It's been a very positive addition. We want to work with local public groups, high schools, colleges, attend health fairs and conferences. As mentioned, we have projects to do for the next 3 years for the duration of this PIP, but one of our first accomplishments was completed in the first quarter of 2013. It was to produce the provider toolkit. This toolkit provides patient, parent, provider education materials and resources. We have included sample office policies, protocols, and procedures. It also contains strategies for outreach to our youth. And the final section profiles 4 Minnesota clinics who have implemented changes to increase their screening rates, kind of a best practices section. I've just included a little snapshot of a postcard we've made that highlights our provider toolkit. Please take a look at it if you get a chance. I have the link at the bottom of the screen here, and here's the description of our provider toolkit. This is the back side of the toolkit postcard. It outlines what the toolkit contains, and you'll see we have a QR code, quick response code there on the left center, the link, and again, the 4 health plans here in Minnesota that are included in this Chlamydia PIP project: Blue Cross Blue Shield of Minnesota, Health Partners, Medica, and UCare, with support from our QIO Stratus Health. Again, we're very proud of this toolkit, and we will be updating as applicable. And now I'll turn it back to Ken. Thank you.
Well, because this PIP Performance Improvement Project is just getting underway, there aren't any real results to show yet. However, at Medica, we've had some efforts in place for several years now to improve chlamydia screening rates. And just to give you a sense of some of the results that we've had, I was our HEDIS manager when the chlamydia measure first came out in 2001, and we were shocked and dismayed at our initial rates and how low they were. And so we definitely identified that this was an area we needed to focus and to do some improving. You can see from this slide that we've always had higher rates in our Medicaid business than commercial, which was pointed out in one of the earlier presentations. I think this is the only HEDIS measure where typically the Medicaid population scores higher than commercial. There's been a lot more attention paid to that group. We also found that in addition to the rates being overall low, that we had some pretty deep disparities among racial and ethnic groups, and so we definitely wanted to do some focus in this area. And so we have some experience at Medica with doing provider toolkits and other types of assistance as the Chlamydia Partnership is working on now. Some things to point out: in 2008, the Minnesota legislature approved expedited partner therapy, so that's been in place now for several years. In 2006 at Medica, we did a focused performance improvement program, and we added a provider incentive for primary care providers. And so we saw rates increase because of that. And in 2010, we added a member incentive where if members were screened, they could get an incentive, and that applied to both males and females. And I think we saw some benefit from that as well. So we've seen a pretty good increase over the last several years. And as we've done a lot of our work, we found that this is certainly a multifaceted issue, and that case has been made very clear in the conversations today. But in order to make an impact on a multifaceted situation like that, you need a comprehensive solution. So we had to identify where our leverage points were. Where could we have some influence? Where could we make some difference? And as a health plan, we had leverage over providers and over our own enrollees, or the patients that are seeing those providers. And so we could direct messaging, we could do incentives and target those points. And I think those of you from different types of organizations, where are the leverage points that you have? Where do you have an opportunity to exert some influence? How can you identify those, and how can you exert some influence into those? Can you identify any champions in your area, whether it's physicians, somebody from public health, or other champions to really help bring this issue forward? And if you have, or trying to put together a collaborative, who is missing from your table, and how can you find ways to make connections and invite others to participate? I don't want to lose sight of the fact that we're looking specifically here at chlamydia screening, but the bigger issue is really of adolescent health. The adolescent age bracket is typically difficult to reach. They don't access health care in general as much as other age groups, and certainly in issues around STIs and other things like that, they can be difficult to reach. And so it really takes some creativity. I think we've seen some good examples of that today. And anytime you can bring other partners to help with this, if you've got school districts, school-based clinics as an example, churches, parents, those are all potential partners in increasing these things. I did want to also mention that here in Minnesota, one of the things that we've done is we've been able to suppress the explanation of benefits, or EOBs, for our Medicaid enrollees. And so part of the issue of confidentiality in terms of EOBs going back to parents are not an issue in our Medicaid business, but it is something we still struggle with in our commercial side because we don't have that same ability legally to do that at this point. And then what's next? What's coming up? Healthcare reform, the January 2014 brings out some new opportunities and things that will make the situation hopefully a little bit easier. As we see more and more people accessing insurance, either through existing channels or through the new exchanges, will make more people insured. And because in most cases, preventive care like STD screening will be covered first dollar with no cost sharing, that hopefully will make it possible to increase rates of screening and care. However, as we've also seen, this can be a political issue, and the debates over reproductive health care will continue. And I think that just adds to the confusion that's out there. Confusion for consumers or patients, confusion for providers. And so we have to work through that and make sure that we're communicating effectively what it is that we're trying to do.